Okay, so I'm glad to see all of you here. I see some former students, which is always nice, and some colleagues, which is always nice. But as Elle and I were saying, we're hoping that there's still a lot of you here who aren't already knowledgeable about these issues and are here to learn some new things. And please ask questions of us later in the Q&A because we really do welcome them. As Marianne was saying, the number of uninsured is quite high and it is rising. According to the latest current population survey statistics, 46.5 million Americans were without insurance in 2006, and another 20 million are estimated to be underinsured. Now this number is a little bit squishier because when they survey people, they don't say, "Are you underinsured?" But there have been surveys that have asked people, did you do without medical care need, prescription drug needs, surgical needs last year because of costs? And they get answers to those surveys. And as well, they have also looked at people who declare bankruptcy because of medical care costs, people who aren't able to meet their needs even though they have some form of insurance. And the Commonwealth Fund, which did a lot of this, their best guess a year ago was about 20 million people were underinsured. The problem is that not only is this high and rising, given the current economic climate and pressures that are coming together, the number is likely to rise even further. As all of us in Michigan are painfully aware, and I just heard this morning on the radio that the new numbers for the number of unemployed in Michigan are up yet again, and today they're going to report even more updates of that. The unemployment rates are in fact rising all over the country. And along with higher levels of unemployment, the spells without work are getting longer. So more and more Americans are without a job that provides them employer-sponsored insurance. The COBRA payment for many of them is too high. And so they end up being without health insurance at the same time that they suffer a loss in income, and in some cases suffer some mental health issues because of being unemployed. And so it all comes together to present a problem. I just read recently a recent survey, a study estimated that every 1 percentage point increase in the unemployment rate leads to another 600,000 children and 400,000 adults without insurance coverage. That's quite a lot. And we have seen at least a percentage point increase in the number of uninsured in the last year, and we are looking to see that happen again in this coming year. The longest spells of unemployment are unfortunately for men 45 to 54 years of age. I see a few likely candidates in here. So you will know what some of the young invincibles in the audience may not realize. That's precisely when you start having health care needs. That's precisely when we start seeing early signs of heart problems and strokes and different kinds of cancers coming in. And so again, some people say, well, so what if you only have a spell of no insurance? You'll get insurance again. If that spell now, the average spell is 5 months, during 5 months, that's when an accident could occur, that's when you could have a stroke, that's when you could discover a lump in your breast. And so unfortunately, healthcare events don't wait until you get a new job that has health insurance. And so I would like to plead to you to please don't just look at the number of people who are uninsured all year or for several years, chronically uninsured, and say, well, those are the people we need to take care of. This intermittent spells without insurance can be serious as well. We also see more and more businesses dropping the offer of health insurance. Since these are predominantly small businesses, that has been the focus of most of this. In the last 4 years, we've had 30,000 small businesses stop offering health insurance. At the same time, large businesses, which really are not dropping the offering of health insurance to their employees in large numbers, but what they are doing is stopping retiree health benefits. And so again, here in Michigan, Southeast Michigan, Chrysler, Ford, we don't need to be reminded of this. We all heard about in the last couple of years of GM and other companies saying, well, we're no longer going to be able to provide retiree health coverage. For early retirees, 55 to 65, that was what they were depending on before they were eligible for Medicare. Even for those who are 65 and over and eligible for Medicare, without any other kind of benefit, many of them are underinsured, and they truly cannot afford to pay for the care that they need. So on the supply side, in terms of having employer-sponsored insurance, all the economic forces are making it worse. And at the same time, on the demand side, what the consumers, the people with insurance are facing, we have two things putting pressure as well. One of them is that employers understandably are saying we have to pass on a lot of these increases in health insurance premiums to our employees. We can't keep paying all of the premium or the same amount of premium. And so what we have seen is that the out-of-pocket premium faced by employees who are still lucky enough to have an employer-sponsored health insurance plan are going up. So from 2001 to 2005, the average out-of-pocket premium that workers faced went up by 30%. Income during that same time period went up 3%. So it's clearly an affordability issue. The average out-of-pocket premium in 2007 for family coverage was $3,276. The average annual income for an hourly worker, so these aren't the salaried supervisory people, but the people who are going to feel the pressure of this increased out-of-pocket payment, is $35,000. So we're basically saying 10% of your income goes to pay the out-of-pocket premium. And this is before taxes. That's not insignificant. And so it's not surprising that the results, looking at national data, have seen that take-up rates are going down. That in the last 5 years, the take-up rates of employer-sponsored insurance are going down. And it's particularly true for the lower paid workers. A second thing that's causing pressure, increased deductibles and copays. Health HSAs, health savings accounts, that's, a big thing. They're trying to get everybody onto them because, consumer gets some skin in the game and they'll be wiser purchasers. So you see deductibles of $5,000 not being that uncommon. Well, for low-income people, that does, in fact, end up being underinsured. So we have pressures from both sides that have to be dealt with. As Marian said, I did want to talk about a couple of myths about the uninsured, and I have that in quotes because I understand that's a handy way to talk about the problem. But the fact of the matter is that the uninsured is not some homogeneous clump of people that's a statistic. The uninsured populate every segment of our population. And so although we will often use the words the uninsured because it's handy, I really try when I can, especially in my writing, to talk about people without coverage, workers without health insurance, retirees without health insurance, because it really, to have the uninsured depersonalizes it and makes it appear as though it is a statistic. Well, before we can design a healthcare policy that cures the problem, we have to have a better understanding of what is the problem that we're trying to cure. Who are the uninsured? Why are the uninsured? And so I wanted to give you just a couple of statistics. I'm not blasting you with tables because I do think most of you probably are aware of a lot of this. And if you're not, you can go to covertheuninsured.org and there's lots of data, lots of tables. Or you can go to the website for the Economic Research Initiative on the Uninsured, which also has a lot of numbers, a lot of numbers. But just a few things. On average, people think the uninsured are all alike. Well, it is true that the typical person without health insurance tends to be lower income and in poor health status than the typical person with health insurance. However, we also see that 30% are what we would think of as being young and healthy. 14% of the uninsured are 6 to 18 years of age. So they've gotten over the ear infections and the colds and all those things that those of us who had small children had to miss work all the time to take them to the doctor's office. Another 16% are 19 to 24, young adults that really at that age, some of the mental health problems start to kick in, but they, typically are quite healthy. So 30% are people that we would consider young and healthy. And some are also reasonably well off. 14% of the uninsured are in households, so they're adults or their children, with annual incomes of more than $75,000. So the question then is, well, if we say, okay, that we're going to cure the problem of the uninsured by just giving everybody a subsidy, why do households 75,000 and over need a subsidy? Is that a really efficient use of scarce taxpayer dollars? Why don't they have insurance? What else is going on? And so you need to find out more about why don't those people have health insurance? Maybe they're 25 years old, working in a high-tech startup company that doesn't offer health insurance. They don't see a need for sacrificing anything. Giving them $5,000 incentive to offer health insurance probably won't make any difference. Maybe there's somebody, a 45-year-old, who has metastatic breast cancer and works out of her home and therefore has to get individual health insurance, $5,000 subsidy isn't going to get her health insurance. So it's more nuanced than just saying, well, just give them money or just force them to do it. That really is a lot of complexity about who they are, which influences what is the solution? How do we, in fact, approach it? The last figure, I put this on all the time because it's still the case that when I go, and I was part of a federal commission a couple years ago that involved going to having community town hall meetings in over 100 different cities around the country, and we would still have people say, the uninsured are all poor, unemployed, homeless, street people. And they would be shocked when we would tell them 83% of the uninsured are workers and their families. And so I keep putting it out there because it's still, right. Those of you who are physicians, your life's work is curing medical disease. As a professor, my life's work is curing ignorance. So I want to put that out there all the time. I don't want people walking out ignorant about who the uninsured are in terms of work status in those households. The second myth is there were 47 million uninsured Americans in 2006. Mary Ann used that figure. I used that figure. I am now telling you that's a myth. It came from the current population survey. It's done in March. They do question a sample of households all over the country, and they ask them, what insurance did you have last year? Did you have Medicare? Did you have Medicaid? Did you have private insurance? Mm-hmm. They go through a whole list of questions, and then they say, so you didn't have any insurance last year? No. And that's how they get the 47 million estimate. There are two national surveys that have been going on, one of them for 20 years, one for about 7 years, that ask month-to-month coverage. And for every month, they say, last time you told us you had employer-sponsored insurance, has there been a change? Oh, well, when did you lose it? So they get month-to-month coverage. That enables you, in fact, to determine how many Americans are without coverage for the entire year, how many are out for 1 year, for 1 month, 2 months, 3 months, et cetera. And from analyses of that data at ERAU, we've analyzed both of them. Our estimate is that there were actually over 67 million Americans who experienced a spell without coverage in 2005. Only 36 million were uninsured for the entire year, and the other 31 million were without coverage for at least part of the year. That really changes the dynamic again of the question of what's the policy recommendation? How do you fix this problem? If you do an annual refundable tax credit, okay, that's great, but what about the sporadically uninsured, the people who are losing their insurance increasingly for short spells that are getting longer because of unemployment? And if you look at these two columns, the first one is the estimate of what percent of different population groups were uninsured for the entire year. And then the second is how many were uninsured at any point during the year. And you see that for these young invincibles, the 19 to 24, for example, we tend to think 1 in 4 were uninsured. Well, it's actually 1 in 2 had a spell without insurance. For 25 to 34, 1 in 5, that's not so bad. 1 in 3 experienced a spell without insurance. And the other one that is often looked at, and it's tied directly to their employment status, are Hispanics. That 1 in 4 are uninsured for the entire year, but again, almost 1 in 2, this number actually went up a little bit last year, are uninsured for at least part of the year. Over the last 6 years, there's really been very little increase in this number who experienced a spell without insurance. Unfortunately, where most of the increase has been is those who are uninsured for at least a year. So, as I said, the spells are getting longer, and they're getting longer for vulnerable populations. The third myth is coverage is coverage is coverage, and that we can, in fact, say, well, 47 million were uninsured, but that leaves all the other millions who were insured, so they're not a problem. And I often say, okay, let's just take a really silly example. Let's say that we have a mandate, and the next president of the United States says, we're going to mandate that every woman and child and man and everybody in the United States of America has coverage for an annual physical of $100. Great. Everybody has insurance. We've solved the problem of the uninsured. Well, that's just ludicrous. So again, if you're looking at what is the appropriate solution, you have to try to figure out what is it that we want covered. Do we even want annual physicals covered for $100? Can't most people afford that? Isn't what we want covered maybe the $2,000, $3,000, $4,000 drug for someone with chronic asthma or diabetes or hypertension? Or isn't that what we want covered? So it really you have to understand that it's not enough just to say everyone will have coverage or everyone must have coverage. And this is where I started adding some things because Marianne asked me to about the different presidential candidates. Senator McCain's proposal, some of you know, is a $5,000 refundable tax credit for a family, a $2,500 for an individual. I'll just point out that the average premium for an employer-sponsored family plan last year, which is going to, I guarantee, be at least 40% lower than what someone's going to have to face when they go in an individual market, was over $12,000. So for someone earning $35,000 a year, and that's the average hourly, right? There are a lot of people below average, obviously. This is not Lake Wobegon where all the children are above average. There's going to be a problem. And what level of coverage will that qualify? Will qualify for both Clinton and Obama. They say everybody should have what members of Congress have. I guarantee you that premium is going to be greater than $12,000 a year. The fourth myth, individuals without health insurance choose to be that way. Well, if you want to get real, I have a son who just turned 18, and for those of you who have teenagers, you'll identify with this. He would say, that's true, Mom. There's no law forcing you to not buy insurance. Well, okay, technically fine, all right, fine. But as economists like to say, it's not just willingness to purchase health insurance, it's also ability to purchase health insurance. And so when you look at effective demand for health insurance, you can't just say, well, they're choosing not to because they're not willing to do it. And there's no law preventing them. It's also ability. And so when we survey people without coverage, only 7% say, I don't need it. And not surprisingly, those are the young, particularly young men, young single men in their early and mid-20s. Over half of them say, I just couldn't afford it. And I just give you some more statistics here of dollars that are of interest. With mandates, that gets rid of the willingness because it's no longer a choice. But what does it do about ability? And that's part of the Obama and Clinton problem. If you're going to mandate, if you're going to require, what kind of subsidy do you need in order for the ability to be there so that people can in fact do it? Myth number 5, U.S. employers spend $400 billion a year for workers' health care. Again, economists get all hung up on this, but again, it's my job to cure ignorance. In reality, workers and consumers pay $400 billion a year for employer-sponsored health insurance. The first line of defense for an employer is to pass that increased price of health insurance on to consumers. If the demand for the product is sensitive to price and we push back, then they're going to push the increased health care costs onto their workers in the form of lower wage growth. If that's sticky, either because of contracts, union contracts or long-run contracts, or the workers say no, then they lose their jobs. So one way or the other, we are paying the $4 billion a year for workers' health care. So I know employers like to think they're paying for it because they're writing the check. But the fact is, it's part of labor costs, it's part of the cost of doing business, and like any other cost of doing business, it's passed on to the consumer as much as possible. And because it's a labor cost, if it can't be passed on to the consumer, it's passed on to the workers. All right? Well, those are the main myths that I wanted to dispel. Then what do we do about it, armed with some of those myths? And I structure this using classic economic tools, change the supply of health insurance, change the demand for health insurance, and the two broad policy approaches are incentivize the market. My mother was an English teacher, and so I have to put that in there because it just drives her nuts that incentivize is being used as a verb because it really isn't, and government regulation. It's like grow the economy. For 8 years, my mother just almost had a heart attack. Grow the economy. So first looking at change the supply of health insurance for the uninsured, these are a lot of strategies that are, that are happening at the local and the state level. A lot of these are already happening. I've actually evaluated a lot of these programs for the Johnson Foundation, for the state of Michigan. They make little dents in the uninsured, but they really don't do a lot. One, expand high-risk pools. That's been popular for a long time in lots of states. The problem is high-risk pools are filled with high-risk individuals with very high costs, and so who's paying their premium? So, you know, some of these ideas really are well-meaning, but they're not getting us very far. I think that might be why most of the presidential candidates these days are really focused more on changing the demand for health insurance rather than the supply of health insurance. With the two broad approaches, voluntary, let's incentivize that market, versus involuntary, the M word, mandates. Voluntary efforts make it more affordable. I mean, that's the classic thing of let the market work, let's just make it more affordable. One way is to reduce the premiums for everybody by making health care costs lower. Another would be to directly reduce the premium through some kind of tax credit or subsidy. And then finally, increase income of purchasers, give a direct income subsidy. No one's talking about that one, so we'll focus just on the other two. Change demand by reducing the premium. You can change provider behavior, change consumer behavior. This is a quote from Senator McCain on his. I can characterize my approach on healthcare by choice and competition, affordability and availability. And the ad that he did, he says that 5 times. Choice and competition, affordability. I bet somebody stayed up all night to make that C, C, and AA, you know, to really make that flow. Right. And that's because really what he wants to do is incentivize the market, get the market to work, change people's behavior by giving them incentives, keep government out, and changing provider behavior. A lot of his favorites, and it's not just Senator McCain, in all fairness, Obama and Clinton also talk about these strategies. President Bush has talked about these strategies. These are, the business community talks about, and these are very popular, which is change you guys, you docs, in the hospitals. We're going to change your behavior. So change your reimbursement to pay for performance, adopt HIT. When I was on this federal commission and we were having hearings all over the place, we went to one hearing and we had all these HIT experts who said, you know, and HIT, if you put it in, it will reduce costs by 30%. Reduce costs by 30%. We have evidence. Reduce cost. It pays for itself within a year for a doctor's office. So reduce cost. Okay, fine. Medical liability. That's another favorite one. And it reduced costs by 30%. Amazing, right? Reduce waste fraud. Reduce costs by 30%. We were beginning to think, wow, pretty soon doctors will be paying us to get care. Whew, this is really terrific. So be a little bit skeptical about some of these estimates. The fact is that we have a lot of studies of all of these. All of them are a good idea. All of them should be done. None of them are going to save a ton of money. They may improve the efficiency of the system. They may improve the quality of the care that's being delivered. They will reduce some redundancies. They will reduce some problems with not talking to each other about who's had what tests where and who's on what drugs. But they're not going to really save enough money to really expand coverage substantially. The second approach is to change consumer behavior, and this is get skin in the game, you know, and this is the whole thing. If we increase cost sharing, consumers will get skin in the game, and if we give them more choice and provide them information, they will do the right thing. They will purchase higher value plans. Once again, this is classic economics. They would take away my union card if I didn't say this is all true. It is. But then again, we have to think about who are the people without insurance, what is their affordability issue, what in fact is their situation, what is their health status, what is their availability, and then we start realizing that it's not that the response isn't in the direction that is being predicted by economic theory. The problem is the size of the response is quite small. And so yes, all of this works in the direction that we would predict, but empirically, so far anyway, every step of this has a very, very small response. The next is just to make it, you know, directly reduce the premium for those without coverage. That's the first line of defense. And so, all right, so we'll use incentives to increase take-up of offers. Well, clearly the way to do that is to subsidize the premium, to reduce the premium that they face. Increase the ability to purchase in a non-group market, all right, make large pools so that the premium goes down. allow people to buy into a group plan, and so they face lower premiums. There are a lot of ways to do this. Some people say we shouldn't just target those without coverage, we should combine it with those without coverage and lower income. Because that's, remember when I said the subsidy before, do you really want to give a $5,000 a year subsidy to someone earning over $75,000 a year who's in very good health and 25 years old? Is that an efficient use of taxpayer dollars? And so we really have to think about that of, is it only people without coverage? Is it people without coverage and low income? And the big problem with any of these approaches is if you say it's only people without coverage, what do you think is going to happen next year to who doesn't have coverage? And we actually have a lot of community-level experiments with, in fact, what some people call crowd out, which in fact is particularly small firms saying, hey, you can buy into that subsidized program, so I'm going to stop offering it because you can buy in. Now, is that bad? Maybe not. It may be that the health insurance they buy into is much better quality than the insurance that they were getting from their place of employment. But it does mean a bigger drain on government dollars. This is Senator McCain, a quote. Let's give every American family a $5,000 refundable tax credit so they can go out across state lines. I'm going down to Ohio and get the insurance policy that suits them best, you know. Well, again, it's just, one is, if you give 82% of Americans who already pay for insurance directly or through lower wage growth the $5,000, that ends up being really, really expensive way per newly covered person. I mean, just do the math. Let's say of the 18%, half of them go out and buy insurance with that $5,000, that they're in the higher income bracket. This is what pushes them over the edge and says, okay, I'm buying insurance. You have to think about the 5,000 that went to the 82% of Americans who have it, and you have to add all of that money with the denominator being, you know, the maybe 20 million who went out and purchased insurance with that $5,000. So it ends up, it's going to be like 50,000 or more per person, new person covered. So it's really, it's sort of an economist's nightmare in terms of that efficient use of tax dollars that we see. Senator Clinton, the tax credits will ensure that working families never have to pay more than a limited percentage of their income for health care. Okay, here's somebody who's tying it to low income, tying it to their ability to pay. So that's a step away from what McCain's strategy is of just giving $5,000 to everyone. This is saying, let's try to target to low income. And Obama has the same idea of, let's in fact target to low income. So that will in fact make it a more efficient policy. But the problem is, I say, show me the money, honey. Because who then is going to pay the taxes that provide the tax credit to only low-income people? And we know how well redistribution of wealth works in this country. The second is directly reduce the premium for everyone, and there are a couple of different ideas. One is providing reinsurance, and the Obama plan is picking up on this. This was something that was proposed 4 years ago. Actually, a friend of mine, a common friend of mine at Harvard, is one of the people who first talked about this and provided information about it. It turns out that healthcare costs are not evenly distributed, that there's a very long tail up there on the high costs, that a very small percent of the population accounts for over 80% of the costs. And if we, in fact, cut off that tail and have government pick up that cost, then the average premium to the rest of us would drop like in half. And so that's not a silly idea. And there are a lot of people who really like that idea and say that's a good way to make it more affordable for everyone, and you don't have to go through the tax system. You don't have to do refundable taxes, upfront taxes, all that complication. And so that's actually a popular idea. Senator Clinton is trying to, in part because I think she got into a lot of trouble with her mandate and forcing business to do something, that she's in fact offering a tax credit for small businesses. So rather than a tax credit to individuals, blanket individuals, she's saying let's offer a tax credit to all low-income people no matter where they work, but let's also offer a tax credit to small businesses to get them to jump on board, all right? We move now to involuntary efforts, which are, as I said, it's the M-word mandates. They can occur at the individual level, where you require the individual to purchase it through the school system, through tax dollars. This is a quote from Obama's plan about children, and it's an example of a mandate at the individual level where the parents would be penalized. And so he would require that children get into a plan. As I point out, 12% of kids under 19 years of age, which is what he's really focused on with the mandate, are without coverage. So that's about 9.4 million people. Letting young adults buy into their parents' plan, that would add another 7.5 million, but unfortunately that leaves 29.3 million uninsured adults. And that's what the Clinton campaign has been attacking him for, of what about all those adults? All right, so yeah, this sounds good, but we have a real problem with that. Just a real quick aside, the 9.4 million kids, the Urban Institute has done some estimates that about 2 million of them are actually eligible for S-CHIP and they just aren't enrolled. So they argue that that number is a little bit inflated, that the number of kids without insurance is actually too high by about 1.8 million. You can also mandate participation at the employer level. This was what Senator Clinton was doing. Although notice I went online last night to update this slide from when I presented it. And Justin, actually, you missed the class that I did for you. And so now you're getting to hear some of this later. She used to say required. Now I love the new language. I love the new language. Large employers will be expected to provide health insurance or contribute. Isn't that great? It's not required anymore. They're going to be expected. It's a social responsibility, Marianne. You'd like that. Healthcare is a social responsibility. This is very similar to the Massachusetts plan. The Massachusetts plan has, in fact, been a penalty to employers who don't offer it, but the penalty is to individuals, the mandate's at the individual level. It's been very successful in getting a lot of people to come on, and in fact, so successful that the state revenues can't cover it anymore. And so it's, again, show me the money, honey. That's part of the problem. So I close with this slide of the problem with the uninsured and what to do really reflects what the goals are. If the goal is to improve access to the right care at the right time in the right place, maybe you don't have to have insurance for catastrophic, just for prevention, to get them in the door, and the rest is taken care of already. If it's to reduce the financial burden of the consumer, you need some kind of subsidy. Maybe it's to reduce the financial burden of providers, help those safety net providers. Increase the economic efficiency of the healthcare system, then you want transparency and you want everybody to understand their true costs, incentivize the market. Last, is it to improve the overall health status of the country and reduce disparities in health status? If that's the case, we have to go way beyond health insurance, because disparities and problems in health status have to do with a lot more than just affordability. So what our goals are influences what the appropriate policy is. And with that, we are moving on. Thank you.